Okay, it's 8 o'clock, it's showtime.
Okay. Thank you, Peter. Good morning, good afternoon, good evening. Welcome everyone to today's webinar. UNFPA is running a series of webinars on expanding contraceptive choices and method mix. Today's webinar is on contraceptive implants. My name is Agnes Chidanyika. I'm a technical advisor in UNFPA, where I lead our work on expanding method mix. A quick guide to today's webinar. This webinar will be recorded. The recording and slides will be shared after the webinar. We have interpretations in 3 languages: French, Spanish, and Arabic. Please use the globe icon at the bottom of your screen to select your language of choice. At the bottom of your screen, you will also see the Q&A chat box. Please submit your questions at any time during the webinar into that box. Do look out for answers from the presenters in that same chat box. Time permitting, we will have a Q&A at the end where unanswered questions will be addressed. Next slide, please. To get us started, I am delighted to introduce Dr. Gifty Adiko, who is the Chief of Commodity Security Branch in Technical Division of UNFPA. She provides technical leadership and strategic direction on family planning. Next slide, please. And over to you, Gifty, for opening remarks.
Thank you, Agnes, and welcome to all our participants. We are truly excited that you can join us. And I want to thank our esteemed speakers, especially our key partners for family planning, WHO, USAID, JPICO, and Avenir Health. UNFPA's mandate is to improve sexual and reproductive health, which is a key effort towards achieving the Sustainable Development Goals. And our new strategic plan from 2022 to 2025 places universal access to reproductive health at the heart of our work, with 3 transformative results, which are ending the unmet need for family planning, ending preventable maternal deaths, and ending gender-based violence, including harmful practices, as commitments to achieve by 2030. We all know that family planning empowers everyone, everywhere, to exercise their rights to choice, bodily autonomy, and agency to plan their lives and families. From the young woman seeking a safe, effective method to modern contraception, to people caught in humanitarian conflict, access to family planning information and services saves and improves lives. But we know that data from our UN Economic and Social Affairs indicates that an estimated 257 million women who want to avoid pregnancy are not using a modern method of contraception. And we also know, and this is very distressing, that the number of unintended pregnancies that occur every year is over 120 million. And this represents a global failure to uphold a basic human right, the right to reproductive health. We know that integration of family planning services into primary health care as part of universal health coverage therefore becomes very critical. And expanding contraceptive options and choices for women, adolescent girls, men and boys, including empowering them to make their own decisions on the timing and spacing of pregnancies, is an important pathway towards economic security and independence. Use of modern contraception increases when more methods of contraception are available. Discontinuation is linked to a number of factors, some of which are related to quality of care and services, including side effects. And therefore, it's important that we make available a wide range of methods that can allow women to choose and switch to a method that is suitable for their needs. I'm pleased to say that the negotiated minimum volume guarantee with manufacturers helped to bring the price of implants down, thereby allowing more countries to introduce this method into their method mix, especially in the public sector. In the last 4 years alone, UNFPA has been procuring at least 6 million implants a year for over 40 countries. In this webinar, you will hear about the introduction and scale-up of contraceptive implants. This is a method that has been under introduction and scale-up in the public sector for the past 10 years. And a lot of evidence and lessons learned have been generated. The lineup has been purposefully selected to cover the main aspects that facilitate scale-up access to implants. And I hope you will enjoy this webinar and leave energized to expand the choice of methods for contraception for your family planning programs. I also hope you will utilize and pass on some of the knowledge you will come across today, especially the guidance and tools that can strengthen the delivery of programs that can save and transform the lives of women and girls and benefit their families, communities, and countries. Welcome once again to this webinar. Thank you.
Thank you very much, Gifty, for setting the scene and emphasizing the importance of choice and options for women and girls. Next slide, please. The introduction and scale-up of contraceptive implants, as Gifty has mentioned, has been highlighted as a success story for expanding method choice. As Gifty has mentioned, UNFPA works with a number of partners, and part of those partners are the Implants Access Program, which is an interagency working group consisting of UNFPA, WHO, USAID, JPIGO, and the Bill and Melinda Gates Foundation. Today, you will hear from these partners to showcase the learnings. Next slide, please. Our first presentation is on Implants 101. I want to welcome Dr. Mark Hathaway, who is the Senior Technical Advisor for Family Planning and Reproductive Health at JPIGO. Next slide, please. And over to you, Mark.
Thank you so much. I'm thrilled to be with this esteemed group of colleagues, as well as all of our counterparts and colleagues across the globe. And I hope this is going to be a fun session for you all. I'm going to start very briefly by showing the way that I talk about implants with clients. And as you can see, I'm holding up an implant, very small, very flexible, very similar in size to the 2-rod implants, which are about the same size, just a touch bit longer. And basically when I talk to a client, I say, these are incredibly effective, incredibly safe, incredibly simple. They're placed in the upper arm. They work because they have a progestin. They're a progestin only method, and that makes them incredibly safe and simple for women to use. And those are kind of the main points. There are some downsides and some side effects that we'll touch on a bit, but basically I want women to understand that these are simple, safe, and effective methods. Next slide, please. I'm briefly going to touch on the history of implants and those 3 implants that are available across the globe. I'll touch on counseling points, who are typical users, efficacy, mechanism of action, and service delivery requirements. Again, I'm going to touch on this. This is a very, very brief discussion. You'll see in this picture to the right, a woman's having an implant placed in her arm. Typically, or ideally, the woman's hand would be under her head. But this is an implant insertion technique, very simple, very straightforward, superficial and subdermal. Thank you. Next slide. So briefly, since 1986, when the implants were introduced to the globe, there was Pop Council spent many years developing the device or implants in 1983, leading up all the way up to 1983. They were introduced in the Dominican Republic and Indonesia in 86 and 87 respectively. And there was very slow but steady increase in uptake. And you'll see by 1991, there was 2.9% uptake in Indonesia. And the increase, as I say, increased steadily but slowly. But then there was a quick jump in around 2012 or so, after the volume guarantees had been established, as Gifty explained a bit. And there was been about a 10-fold increase in uptakes globally between 2012 or so and 2018. And it's still steadily increasing. Next slide, please. So as Gifty mentioned, Dr. Gifty mentioned, choice is paramount when a woman is picking a contraceptive method or an adolescent. So some women may be very interested in an effective method. They may be interested in a method that is utilized and they don't have to do anything, what some people refer to as implants or IUDs as forgettable methods. But other women may want a method that provides them more protection for STIs, like a condom, or some women may want something that has an impact, improvement on their menstrual periods or their bleeding profile. So a hormonal IUD, for example, might be utilized. So many women have different reasons why they choose methods. And we want to make sure that we allow women to have those choices, understand what they want out of a contraceptive method, what they desire, and then help them choose the best method that's suitable for them. Next slide. So we know, as I kind of just mentioned, basically implants are safe for just about any woman or adolescent that wants to avoid pregnancy. They're incredibly safe and simple. Very, very few contraindications. And our colleagues will talk about that a little bit in a few minutes regarding the WHO contraindications or the WHO medical eligibility criteria. However, the uptake varies tremendously from country to country, within countries, across various cultural contexts, from areas in one place to another. And that has to do with multiple factors. They include what one of my colleagues refers to as the multiple Ps: policymakers, the providers' biases or providers' perceptions, public perceptions or misperceptions, promotional or materials, patients' perceptions and misperceptions, and procurement sometimes can have an issue or have an impact on uptake, stockouts, and there may be not even just a method, but perhaps the consumables needed. Next slide. So this is touching on a study that was done several years ago on efficacy. And you'll note that the implants are actually the most effective contraceptive method available. They are actually more effective than male sterilization or female sterilization. But the differences are very, very slight between the IUD types that are out there, the hormonal IUDs and the copper IUDs. Implants and male sterilization, female sterilization, they're all roughly around the same in terms of incredibly effective. Failure rates are really, really small for all of these methods. Next slide. So what that effectiveness information led to is a chart that it's what's referred to as tier-based effectiveness or tier-based counseling. Some women or some of us like to use counseling techniques to help women choose a method. And this is one of the methods or one of the tools that can be used. You'll see that the top tier are the most effective methods. The middle tier that includes injectables, lactation and amenorrhea methods, pills, patch ring, those are the moderately effective methods. And then the lower tier are the least effective methods. But as I point out, effectiveness is not the only thing that women choose when they're picking a method. So you want to make sure that a woman chooses the method that's most effective or most desirable for her and her needs. Next slide. This is a chart and a presentation that we used several years ago, or developed several years ago. And you'll note that I've highlighted here the mechanism of action of implants. So there's basically 4 mechanisms of actions of different contraceptive methods throughout the globe, used throughout the globe. And you'll see that implants actually have 2 mechanisms of action. The primary is it slightly or inhibits ovulation. So the egg is not released from the ovary. It also has an impact on the cervix. So progestins typically have an impact on the cervix, thickening the cervical mucus and thereby reducing the sperm's ability to enter the uterus. I want to also point out that all of the contraceptive methods that we use throughout the globe, all of them prevent fertilization. So the egg and the sperm never get together. So none of them provide or are abortifacients. None of them cause abortions. Next slide. So these are the three methods that are available throughout the globe. You'll see on the left the levoplant, and then the middle picture is Implanon NXT, or the single rod implant, and then Jadel on the far right, another 2-rod system similar to the levoplant. And this is the price, as Dr. Gifty mentioned, is reduced tremendously by the minimum volume guarantee established in roughly 2010 with the manufacturers and several donors and USAID. Countries also had a large impact on that. Next slide. This is a chart that just kind of compares the various methods around the globe, and you'll see across the top the manufacturers and then the formulation. All of those are progestin methods or progestin hormones. None of these contain estrogen. There's the 1-rod method on the far left, the Implanon NXT, and then the 2-rod implants, the levoplant and the Jadel. And you'll notice the duration is slightly variable, and that has to do with pre-qualifications. Every country has to go through pre-qualifications and registration in their various countries, and so that depends on how those are established and what data is used. The average insertion time, as you'll see, is very, very small or very minimal, 2 minutes or 5 minutes for the 2-rod systems. Next slide. There's lots and lots of training modalities, training tools used. We'll talk about those in a touch. There's a WHO medical eligibility criteria, which all of us on this call should be aware of and utilize. Another one of our colleagues will talk about in a minute. Next slide. This is just one of the job aids that's utilized, and you can see the picture up in the far on the right side. The 1-rod implant is inserted in the upper arm, slightly above the triceps, superficial and subdermal. Next slide. This is a depiction of the 2-rod system, same area of the upper arm, and this is placed, the 2-rod system is placed in a slight V-shaped area with a trocar that places the 2 rods, superficial and subdermal in the upper arm. And then there's you can see in the up right in the small box, a list of the consumables needed. And there's very, very, very few. Typical, most clinic systems or setups will have all of those devices, except for the perhaps lidocaine, which is somewhat difficult to come by. Next slide. And I will stop there. Thank you very much.
Thank you very much, Mark, for the overview of the 3 implants that are currently available and some of the key considerations in service provision. Now we will move on to hear about the global trends on implant use. Our next presenter is Dr. Christine Beach, who is Senior Demographer at Avenue Health. Next slide, please, and over to you, Christine.
Thank you. In this presentation, I'm going to walk through some of the global trends of implant use and talk about where we can access data to monitor these trends. Next slide, please. So in the talk today, I'm going to go through some different trends, prevalence, talk about the type of women we see using implants, and the sources of which women access implants. I also am going to talk a bit about the impact of COVID-19 and if we've seen evidence of it slowing down the increasing use of implants. And then I want to touch on discontinuation, as I know that's an area of interest for a lot of people when talking about expanding implant access. Next slide, please. All right, so first I want to talk about where we can access data on implant trends. First, we have survey data. This is, for example, DHS, PMA, and MIX, which are all country level surveys that are conducted. And in these surveys, we can find a variety of data. All of them measure prevalence. We can look at method mix, type of users. In some of them, we can look at the source where women access implants. A little bit, and you'll know with the asterisks, on method satisfaction, do women like using implants? And then again, in a few of them, we can look at discontinuation. HMIS data, Health Metric Information Systems, is data generally collected by countries on their programs. We can use this data when it's available to us to look at long-term and short-term trends. One of the nice things about HMIS data is it's usually available monthly, as clinics report every month the services they provide. And it also lets us look by brand of implant. Additionally, there's supplies data, which any of you can access using an interactive website at the Reproductive Health Supplies Coalition, where you can look at trends by country, by funders, etc. Next slide, please. All right, so here we have some global trends in implant use. And for this illustrative purpose, I've shown married women data. This is all survey data. And we can see at the top map in the late 90s to early 2000s, implant use was very low. The highest use was in Kiribati and Palau, where 5% of married women were using implants, but only 11 countries in the world had implant use of over 1% of married women. As we look at the second graph, we see an acceleration in use in Africa. At that point, Kenya had the highest use in the world, about 10% of married women, and 50 countries had use of 1% or higher. Looking at the bottom map, we see the most recent surveys in all countries, and we see that there's been growth in Africa, Asia, and Latin America. The highest use now in the world is in Rwanda, where 26% of married women were using implants in their most recent survey, and 25 countries have implant use of over 5% of women. 9 countries now have implants as the most common method of use of all methods. And these are all in Africa and Asia. And we've seen that a 2018 article showed that for about 10 countries in sub-Saharan Africa, implant use has been the main driver of MCPR in recent years. Next slide, please. So here I wanted to look a little bit more at breakdowns in trends. So before I showed trends for married women, I want to show that implants are also common among unmarried sexually active women as well. You can see on this map, this graph on the left, Benin, which is the blue lines. Unmarried sexually active women have higher implant use, this dotted line, than the blue solid line. The trends in Benin are similar for both married and unmarried sexually active women, as well as Rwanda. I also looked at a few different breakdowns by education, urban, rural status to see if we see a predominance of implants in one sector or the other. And actually, I didn't find a pattern. So you can see here, these are all countries with high implant use, looking at implant use in rural and urban areas. And we see kind of a mixed bag of results. In Rwanda, rural use is higher. In Mali, urban use is higher. And then the other 3 countries, it's pretty similar between rural and urban women. Next slide, please. All right, we then want to look at where women are accessing their methods. So these are 37 countries with demographic health surveys where over 1% of married women are using implants. And you see that the vast majority of women receive their implants from the public sector, which includes support from NGO partners. All African countries, which are in the purple, have over 75% of access from the public sector. But within the public sector, source can change. As you can see that here in Senegal, which has had a large increase in implant use over time, the predominant source has switched from hospital-based insertions to health post-based insertions. And over this time, use has grown from 1% in 2005 to 10% in 2019. Next slide, please. Here's some data that is currently under review, looking at change between 2019 and 2020 in terms of the estimated number of implant users in 15 countries that track twinning works in. And what we wanted to look at was if trends in implant use, which have been increasing over time, were stalled because of COVID-19. During the initial period of global lockdowns, there was worry that people wouldn't access implants because of the need to see providers. But we see that only in 3 countries was there an estimated decline in users, and in most countries there was, the large growth in implant use, keeping track with the trends we've seen in the past. So we do not see that COVID-19 significantly impacted our trends in terms of increasing implant use. Next slide, please. Finally, talking about discontinuation, we have a couple of different ways we monitor discontinuation. First, we can look at it through survey data. And so you can see the pink line on the left-hand graph is global discontinuation rates. And this is for the first 2 years of use. Then I've plotted some country level discontinuation, which comes from the demographic health surveys. And you can see these countries are all within West Africa, but have noticeably different trends or patterns in terms of discontinuation. We then also are starting to see more and more discontinuation data coming from HMIS sources. For example, here we have data from Kenya. The gray is the number of insertions, and then we can look at the purple. The light purple is the number of removals that are recorded in the HMIS system. And then we have also information about expected removals, which we can use as quality checks based off of different discontinuation trends. Next. Oh, and I just wanted to say one more thing, sorry, about discontinuation. The 2 most common reasons for discontinuation we've seen in the data within the first 12 months are side effects and discontinuing to become pregnant. Next slide, please. In conclusion, we have many different sources that we can use to monitor implant use, and each provides their own unique piece of information. We've seen implants continue to increase and even accelerate the increase, especially in sub-Saharan Africa. We've seen married women and unmarried women choosing to use implants, and they're overwhelmingly receiving these implants from the public sector, with efforts on task sharing being reflected as we've shifted from hospital-based to lower-level health facilities. COVID-19 did not impact implant growth as far as we've seen, and that we've also seen that few women have had issues having their implants removed. That's a slide that's available as well in this deck. And then discontinuation patterns vary by country, even countries with similar family planning use overall. Thank you.
Thank you very much, Christine, for this insightful data on use and access, noting the impact on MCPI in some of the countries, as well as the reasons for discontinuation. In UNFPA, key focus area for us is health system strengthening and readiness for introducing or scaling up access to contraceptive methods. Our next speaker will highlight some of this work. I will now give the floor to Desmond Koroma, who is our technical advisor in technical division of UNFPA, leading the monitoring and evaluation of family planning programs. Next slide, please, and over to you, Desmond.
Thank you very much, Agnes, and welcome everyone. Next slide, please. So here is a very good segue to what Christine was saying. She was talking about use. Here we are actually talking about what we need to do to ensure that our national systems are ready to introduce and ensure implant is actually used in service delivery points. So we are not talking about a silo system. We're talking about a system that should already exist. As you can see on the right side of this slide, we're talking about issues that are aligned to the WHO building blocks of the health system. And the issue is it should be in an integrated manner, not just concentrating on one, because it's an organic system. But most importantly, circumstances change in countries. So our system should be able to be strong enough and adapted enough to these changes. So for instance, you might move from normal service delivery situations to emergency situations, and those systems should be resilient enough and strong enough to ensure that the implants or any other commodities are available in service delivery points for use. We will go to the next slide, and then we unpack this a little bit. At the policy level, we're not talking about an implant standalone silo policy, but also something that is integrated in our health policy or family planning policy, or what exists in in the national environment. But the most important thing we want to look for in our countries is that the policy authorizes this, the provision of implants at the lower level. So I'm sure my colleagues will be talking about tax shifting, but at that lower level, it is important that this is the case. And the systems are also ready at that lower level for that to happen. And once that is the case, before it is introduced, it has to be registered, it has to be in the essential medicines list. But I think you had Mark talk about job aids and guidelines, and those things have to exist in our systems. And we also work with UNFPA and our partners. We also work to ensure that government invest in the procurement of implants. So we check whether in fact there is an increase in government's investment in this, but not only the procurement of it, but also at the service delivery level. And our national system should ensure that also we can quantify, we are able to actually do a very good quantification and supply planning so we can procure quantities and ensure that our distribution systems are working very well. And we can have our health information systems that can actually provide us the data for decision making and all of this. But one important thing, like we said, there will be moving from policy to practice. It can be cascaded to the lower level policy wise, but it takes time for us to have all that it takes to be at that level. For instance, human resources, right? The tax shifting itself can be allowed at policy level, but it takes a while for us to have trained staff, not only for the insertion, but also for the removal of it. And here at UNFPA, we have added an important element of this system, that demand itself is an important element for us to drive implants in countries, because we need to have strategies in place, and I'm sure my colleagues will talk about this, increasing our awareness and ensuring that we have good behavior change communication so that people are aware and they know that what is happening and they can come to the service delivery points. What we are going to do now is to present to you tidbits, just tip of the iceberg of some of the data that we have been gathering at UNFPA and what we see to respond to some of these things that we say. Next slide. So here we're talking about availability of implants at service delivery points. Even the policies have to be in place, and then the tax shifting has taken place, and the distribution mechanism must also be working very well. We have here, we are not picking on these countries, please. We are just using them as examples. There are other, we conduct this survey in about 20 countries every year. We have in the developing world, and it is actually a facility-based survey about all the contraceptives, including implants. So you can see we have an example here of Burkina Faso where the availability of implants at service delivery points last year in 2021 was really very high at all levels, but that is different from Yemen and Haiti, for instance. And when you check this, the reason for this is really highly either a broken supply chain system, for instance, in the case of Yemen, and of course you have challenges with availability of health staff. But take note of the issue of Haiti, right? You can see the highest reason here we're talking about is that in some of these service delivery points that are not providing implants is because they don't have they reported that we have low client demand for the commodity, and it speaks to the type of work we need to do to ensure that women know about this, especially the issues that Mark was talking about, side effects and the rest of it, and then they can come to they can be confident enough to ask for the service. Next slide. And this is we also check about stock out at all levels of service delivery points. So you can see we have 3 examples here again. That's most often when we check, At tertiary level, it is always available, but we need to do more so that we can have implants, the stock out less at the lower levels, that is at secondary and primary level. Again, here, most often, it is the case of a broken supply chain. And that's the system that we need to continuously work with our partners and the governments to ensure that the commodities can move and they are available at service delivery points. Next. And this one is about trained staff, right? So you can see trained staff again, the picture is the same. Trained staff are available at the higher levels, but at the lower levels, trained staff are not always available for the provision of service. Next slide, we want to end with this one. Next slide. So this is what I was talking about, that you have instances. This comes to us in two ways. There are countries where the availability is like close to 80% of all service delivery points, but the 20% or less that are not providing this service is actually because of certain reasons. But you can see the blue barriers, and is because of low demand. And we think that evidence-based demand generation for implant is also a part of strengthening your system to ensure that it is ready for an uptake of implants. So I will leave you with this, and I hand you back to Agnes for the next session. Thank you very much.
Thank you, Desmond. Certainly, health system readiness plays a key role in ensuring uninterrupted supply and access to not only implants, but all modern contraceptive methods. The next presentation will outline the key considerations in expanding access to implants. Dr. James Carey is the head of contraception and fertility care unit at WHO. Next slide, please. I will hand over to James. Over to you, James.
Yeah, thank you, Agnes, and thank you, colleagues, for inviting me to participate in this webinar. And on the next slide, I just highlight the areas that I hope to cover in the next 8 or so minutes. And mostly, I'll actually focus on the tools, because I believe that the guidelines from WHO are quite well known. Then I'll talk about task sharing for implants and expanding access to removal. And the next slide, I highlight the previous slide, please. Yeah, apologies, looks like, just move to the next slide. Yeah, apologies, looks like we have missed one of the slides and maybe I didn't notice this, but what I wanted to highlight is that WHO has 4 main guidelines on family planning: the medical eligibility criteria, the selected practice recommendations, and the global handbook for family planning providers. And we have also a guideline on ensuring human rights in contraceptive services. These guidelines are very important, and I call upon you maybe after this session to try and look them up. It's very important for countries to look at as much as possible to align with these WHO guidelines, because they are evidence-based and they receive input from various stakeholders. And for this, it is very critical that we align to these guidelines. I would like to spend actually more time on this slide, which looks at the tools that can support family planning providers. These tools are derived from looking at the guidelines. And several years ago, we did develop a tool to guide women through their postpartum family planning options, a tool that we called the Family Planning Postpartum Compendium. And this compendium was really just focused on postpartum period. You can access it at that website that is shown on the slide. And we actually did a pilot study to look at its feasibility, functionality, and acceptability. And what we found from this study was that one, it was feasible to use the app and was highly acceptable among providers. And the providers actually recommended that we should have a more comprehensive tool, so not focus only on the postpartum period. And this led us to actually create the tool that is currently available, which is the WHO Contraception app. This one is available both on the Google Play Store, or if you're on iPhone, on the App Store. So if you go there and type WHO Contraception, then you'll be able to see this tool, and you can download it as an app on your phone. That's just a screenshot of my phone showing where the app sits on the phone. You need internet, you need a smartphone to download, but to use it, it doesn't depend on the internet. So this is a very important tool for providers, because you can go through the conditions. If you choose a condition, for example, if you choose diabetes with vascular disease complications, then down there you can see the WHO recommendations for each method. And I think the challenge is for us to make sure as many providers that we are supporting, or if we are providers, that we have this tool to ensure that we provide quality services to our clients. And if you want to check the references, there's more information that you can find, including why the decision and what are the reasons maybe for contraindication. So if we take anything home from this talk, is the importance of having this tool as really part of our armamentarium to ensure that when we provide implants, we provide this safely, and it is quite an important tool to use as a counseling support tool. And next. So as you can see, in terms of the postpartum period, progesterone-only implants can be used immediately postpartum, and we actually do not have any contraindications for progesterone-only implants that we are discussing today, though, as you can see on that table, there is other methods that you can use during different periods. So I must say one of the big progress that we've made with postpartum with implants is really they've really expanded choices for postpartum women. And this has been a very good progress, because we know that in the postpartum period, the unmet need tends to be quite high. And next slide. So turning on to task sharing, we have the task sharing to improve access to family planning. We have a summary brief, but I've also provided links to other resources where you can find more information on task sharing, even beyond family planning methods. And I would like to highlight on the table that is there on the right, you can see implant insertion and removal. And at the top of the table, you can see who is eligible to do this insertion and removal. And you can see for nurses, for implants, for nurses, midwives, associate clinicians, non-specialist clinicians, and specialist clinicians, all of them. So there's actually no reason to restrict these roles either to only medical officers or to specialists. Midwives, nurses, and others can be able to do this. And also, with appropriate training, auxiliary nurses and auxiliary nurse midwives can also be able to provide implants. Under rigorous evaluation, community health workers can be able to provide implants. So implants now, and as we have heard from a previous presenter, can easily be provided in the primary healthcare setting, and they need to move from the secondary and tertiary levels and be expanded to be available in the primary healthcare setting and even in the community. When we think about task sharing, some of the key consideration is that training is very critical, and training and supervision are very important. It is important to have the supplies and all the other commodities that go with safe insertion of implants. And then also we must retain lines of removal, and I'll talk this more when I refer to the issue of removal. It is important to retain monitoring and evaluation systems, and also to have not only the task sharing done, but to ensure that there are protocols, regulations, curricula to support this new scope of practice. And on the next slide. So I think the expansion of implants over time has already been discussed, that they've really expanded access and use over time. But when we look at the issues of removal particularly, for WHO, we recommend that providers must not refuse or delay removal when women ask. It doesn't matter the reason, whether it's a personal reason, whether the reason seems appropriate. When women ask for refusal, for removal, this should not be refused or delayed. If the implants are difficult to remove, then a provider with the necessary skills should be available, either at that facility or the client should be referred to a place where they can have this done. And whenever possible, removal should be provided free of charge. And this is very important so that cost does not become a barrier for removal. And next slide. Yeah, so I think I will stop there. Thank you.
Thank you very much, James, for highlighting some of these critical considerations in service delivery, and also listening to women when they do decide to have the implant removed. Just to say, there's some very interesting questions that are coming up in the Q&A chat box, so keep the questions coming. For example, there's been some questions on discontinuation, and also I think James' presentation has probably answered some of the questions on what are the reasons behind the scale up in sub-Saharan Africa. The presenters will continue to monitor and answer to your questions in the chat box. Our next presenter will highlight the key resources for providers, policymakers, and program managers. I want to welcome Kate Derringer, who is the Senior Clinical Family Planning Advisor at USAID. Next slide, please, and over to you, Kate.
Thank you very much. I'm pleased to introduce a suite of key resources for expanding quality contraceptive implant services as part of this session today. Next slide. First, I'll highlight the global good in family planning and reproductive health clinical professional development, the training resource package for family planning. The training resource package platform was launched in 2012 by USAID, WHO, and UNFPA to meet the need for a standardized cache of vetted family planning and reproductive health clinical content, curricula, and training materials. Next slide, please. The TRP offers a collection of high-quality modular resources that can be used to design, implement, and evaluate family planning and reproductive health competency-based training. It's consistently updated in order to enhance opportunities for professionals to advance their clinical acumen in family planning service delivery, and is derived from the global evidence base, practice guidelines and standards, including the WHO Family Planning Handbook for Providers, the medical eligibility for contraceptive service delivery, and standard practice recommendations. Next slide, please. In 2020, the Training Resource Package Steering Committee underwent an intensive user engagement process to inform a re-engineering of the platform that would enhance users' experiences, accessibility, and functionality. The new platform now features augmented content discoverability, curation, and personalization, low bandwidth modalities, and a clinical educator peer community forum. Next slide. The contraceptive implant module was revised in 2021 to feature deep implant removal procedures, new anatomical site placement graphics, sterile techniques, and recent clinical guidance. Next slide. As a whole, the TRP library offers 4 cross-cutting and 15 contraceptive method-specific modules, each featuring session plans, facilitators' guides, presentations, handouts, evaluation tools, references, and demonstration videos for method provision and counseling. These are all available in French and can be used in pre or in-service education. They're appropriate for a range of learners across clinical and community-based cadres working in public or private sectors. Next slide. The training resource package can and has been adapted to be fit for purpose in various contexts and includes a dedicated section to guide users in adaptation. For example, the hormonal IUD module was used by the Zambian Ministry of Health to develop service delivery guidelines recently, and the library was also updated for adolescent and youth populations by professional associations and partners in Tanzania and Ghana. Next slide, please. Please do join us in ensuring that the training resource package is in the hands of clinical educators, health workers, program managers, trainers, and those who can best benefit from the resource library. The TRP is available at fptraining.org. Next, we'll look at key global technical products and guidance that inform the training resource package and are highly relevant to quality contraceptive implant service delivery. Next slide. As mentioned, the WHO Global Handbook for Family Planning Providers serves as a key document to ensure quality and safety of family planning service provision. WHO and partners are currently preparing a revision to the 2018 publication, and the 2022 version will soon feature an updated contraceptive implants chapter. The chapter will be updated to align with current practice guidance in order to improve client care and incorporate new recommendations on contraceptive eligibility for women at high risk of HIV infection. Next slide. Also emphasized, the medical eligibility criteria was first developed in 1996 and represents global guidance for the safety of contraceptive methods in the context of specific health conditions and characteristics. The most recent version is in its 5th edition, and it was updated to include the Sino implant, globally marketed as Levoplant, into the guidance. A mobile application was mentioned, and it is widely available, as well as the MEC wheel and reference chart, and they serve to enhance point of service experiences for providers and clients alike. Next slide, please. Next, I'll highlight a curated collection of 20 essential resources on contraceptive implant removal, developed by the Global Implant Removal Task Force. These resources are categorized into 4 areas that include background and advocacy, service delivery, measurement, assessment, and country and programmatic experiences. You can find this resource and many more specific to service delivery, demand generation, product introduction, and country experiences on the Knowledge Success platform at knowledgesuccess.org. Next slide, please. Also available is the Implants Toolkit, featuring program management guidance, communication materials, and various policies and guidelines for introduction activities, as well as experiences with mobile service introduction, social franchising, and integrated family planning programs. This resource is also available at knowledgesuccess.org. To the next slide, please. And lastly, JPICO's Providing Contraceptive Implants Learning Resource Package is an excellent complement and source of information for contraceptive implant services. It includes reference manuals, trainer and learner-directed materials, another set of webinar slides, presentation graphics, links to additional literature, and information regarding the method. This resource is available on the organization's website and easily accessible. Thank you for your attention today and for your continued dedication towards improving access to contraceptive choices and method mix. Agnes, back over to you.
Thank you, Kate, for these useful resources which countries can access and adopt for their settings. Our final speaker will draw attention to the importance of gender transformative and human rights-based approaches in family planning. It's a pleasure to welcome Dr. Nafi Diop, who is the Chief of Gender and Human Rights Branch in Technical Division at UNFPA. She's leading UNFPA's work in this area. Next slide, please, and over to you, Nafi.
Thank you so much, colleagues. I would like to start by quoting a colleague, a representative, Dr. Ademola in South Sudan. And yesterday he was saying, you know, we have done a lot of progress. However, if we want to accelerate what we are doing, we need to change our dance steps. And we need to do things a little bit differently. So, of course, we have today, you know, brilliant presentation on, you know, the implants and the health systems, etc. But I want to take you in another journey that is really complementary for UNFPA, which is, as we know, you know, that's you know, family planning, you know, and the reducing unmet need for family planning means also using, you know, a combination of integrated, multi-sectoral, generational, and gender-responsive approaches. And for us, we have take the, you know, the strong commitment in our current strategic plan, of course, to continue the fantastic work that is being done to, you know, make implant available and to strengthen health system and all. But we also think that it is important to look at those other aspects that have influence. And I was really interested in hearing, you know, that even, you know, for, you know, the uptake of the implant, the removal of the implant by the health providers, and, you know, the service that in general, health workers, including midwives, are providing, there is definitively a gender component that is part of it. And we need to integrate it into the curricula of training of all those health workers if we really want to make the last mile you know, acceleration that is needed. So here, what is gender transformative approaches? It's about, you know, challenging gender inequality by transforming harmful gender norms, roles, and relation through programs and strategy, and foster progressive changes in power relationship between women and men. And I was interested to see in the question and answer, one you know, a colleague talk about couple. Can we change the name to, you know, couple choice, for example? Which is great, you know, he is already a gender sensitive person. So I would like to just say that you know, include and is based on human rights-based approach that we also heard, you know, from the WHO colleague who mentioned, you know, some of the human rights elements when it comes to the woman wanted to remove the implant. And we do know that there is a lot of issue there, including, you know, the involvement or not involvement, and a lot of discrimination and stigma from the health providers, and the inclusion or not of the partners, the men, because it is a couple at the end of the day, to really make that final decision. But what we want to say here, and that I heard a lot, you know, about the discontinuity of using implants, for example. If there is a need and there is some medical reason, and the woman has a right to request to be removed, to remove the implant, you know, in that case, she still, we do hope that if she still do not want to have a children, she will have the agency and the decision making to request another method and pass and maybe reduce the time between, the use of different methods in order to avoid the pregnancy because she's not ready to have the next child or she does not want anymore. So those are the things that we are currently, want to integrate very strongly into our family planning response. Make sure that, the rights is respected and the reproductive rights is respected, with informed consent, independent decisions, and increasing, understanding and improving, strategy at the community-based level. So next slide, please. That was the introduction. The introduction was long. Actually, if you could go back, I'm sorry, I'm not yet at that slide. Yes. So I just wanted to say that, there is a lot of, we know that, social and gender norms influence, of course, the use of family planning and particularly the implant that we're talking about today. Women derive social economic status by conforming to cultural expectation and social expectation. And that is more and more demonstrated, by data. And they fear the potential, health consequences also and social in using family planning. We know that women's autonomous decision-making and agency, are powerful determinants of contraceptive use and implant use, yet they are constrained by social and family power dynamics, but also the systems, the health system itself. And then we have to look very carefully at the adolescents and youth, a community, which is a huge community in a lot of countries where the CPR is low, and which, definitively are facing strong barriers and include, at different level, individual, interpersonal, social, cultural, and in the healthcare system. So we need to look at a little bit that component and also, look at the fact that men are largely dominating decision-making regarding our family side. So next slide, I would like just to show you quickly and very interesting data here that should be used as an opportunity, because it says that we agree that it is a woman's responsibility, not a man's responsibility, to avoid getting pregnant. So you can see the orange bar, how it is high in several countries that are listed here. Quite interesting and means opportunity. But do they have that decision making and that agency is the big question. Next slide. Here, what I wanted to say is that, in terms of women decision making, we have an indicator SDG 5.61. Next slide, please. Which was showing that actually, about 57% of women are able to make their own decisions. But I would like to see that this is not, it's a number of countries, about 50 countries where this data have been available. So there is still quite a lot of work to do in that particular area. Next slide. And then for us, also quite important when we are talking about human rights-based approach and women agency and decision-making is the fact that, we are seeing that in 2020, 22% of the countries where we have been able to measure our indicator SDG 5.62, they are, low restricting really the use of contraceptive services by couple, spouse, etc. So we really need to continue to work on that level. And of course, when we're talking about gender transformative approaches, we are also talking about the institutional and the policy system. And then the next one, I wanted to just highlight the fact that we have some principle here, at UNFPA particularly, that are related to bodily autonomy and agency. And their implication, for program is that people and women and men, young people, young adolescent girls need to have, of course, the knowledge. They need to have and to know and to demand their rights, for their bodily autonomy and integrity, they need to have that agency and ability to make and execute their own decision without pressure or barrier from the system, including the health system or the family, the husband, the partner. They need to have an informed voluntary decision-making supported. They need to have a client, we need to have client control methods that are offered. And I think that, the previous presenter, talk about that clearly. But as I said, if the implant, for example, is not what works, for that woman, she definitively needs to be able to have and be offered by the health providers, some other methods. And we know that there is a lot of bias, including gender bias into that. And then, we need to continue to support those gender norms into the community. And what that means exactly? That means also new partnership for us, new partnership with women-led organization, new partnership with those, that are, within the community and that can, help us understand how to offer those services. We cannot stay in a room as medical doctors and Ministry of Health, agents with partners, and designing, programs, approaches and all. We need to include, the beneficiary. And I think that I will just stop there and say that thank you so much. But this is a new dance for us as the UNFPA, and we're very happy to provide more information on what we need about gender transformative approaches to both look at the health system and strengthening it, and look at all the discrimination, gender discrimination there, and at the same time, improve demand generation. Thank you.
Thank you very much, Nafi. Your presentation came at the right time, because I think we had some comments on what about decision making. We were only talking about the product. It's a right. We have to make sure that women have the decision making on contraception. So your presentation came at the right time, and I think has addressed some of those concerns. We have been checking the Q&A box, and our presenters have been responding to all of your questions. Please do check for the responses that have been put there. I think now I'll just, since we have a few more minutes, I'll just open for some questions. Please do raise your hand if you have any questions. We can take a couple more questions in addition to what we have responded to in the chat box. I'm not seeing any hands. Please do feel free to raise your hand if you have any questions. There were questions on discontinuation, some of the data. Christine has responded to those. I'll just check for any new questions. All right. Sita says is not able to raise his hand. Smitha, are we able to open the mic for Sita, Shankar, Unava to ask their question? Sita, are you able to speak?
I don't see Sita on the line anymore, Agnes. So we can go to the next attendee who's raised the hand.
All right. Amir Modern, please go ahead. I see your hand is up. Okay, Megan, your hand is up. Please, can you go ahead? Smith, I think we have a challenge with people being able to unmute and speak. Megan, can
Sure. Sure, I just was able to unmute. Thanks for that. Yeah, I just
wonderful.
have a question. I think it was James or Desmond, I now forget, who shared some, it was Desmond, who shared some data about low demand being a contributor to facilities offering implants. And it struck me that, yes, it's possible that there's low demand, but like, is low demand really an effect of what those communities nearest those facilities are used to getting at those facilities, right? Like, is the demand the issue, or is the lack of supply also lowering the demand? And maybe is there an interactive effect between supply and demand that we need to also pay attention to?
The point I was making is that when we conduct this survey, we ask whether they provide the range of commodities, and implant is just one of them. And what actually shows up in that data is that for those who say we don't provide, we ask them, what is the reason? And what shows up in that slide is a range of reasons. And for some countries, two categories. There are some because the commodity is just being introduced at a given level, so is because women don't know about it. We don't even, is low demand, so we don't provide it. We stock it, but there's low demand, so the provision is very low. There are others where, for instance, Burkina Faso is an example, where you can see, if you look at those graphs when you get the slides, you can see they're almost way up between the 80s and 90s at all levels. So you have like 4 or 5% of their service delivery points that maybe they are far away. For instance, those we call hard to reach areas, and they are not providing it. It's because women are not coming. So it's in both ways. And this calls for a deeper understanding, again, context specific in the country, to know what actually needs to be done. But it's not just one reason, right? There are so many other reasons. We picked on that in countries where that reason shows up as significantly very high. I hope that throws light on what you were asking.
Hello, this is Sita. Can I be heard now?
Yes, we can hear you, Sita. Please go ahead.
Thank you. I did not get an answer to my question, so I'll ask it again. I wanted to know whether UNFPA in India is doing any advocacy with the government for implants to be introduced in the basket of choices, because it's been going on for many years. But I just wanted to know what the latest advocacy work is being done in India.
Thank you, Sita, for that question. What UNFPA does with all the governments that we work with is to encourage the inclusion of all methods that we know are available in the public sector. I believe that work is ongoing in India. There's also ongoing discussions of other new methods that are under discussion with the government of India, implants included. I hope that answers your question. Bruce, Bruce Campbell, please go ahead. I see your hand is up. If you're
yes, thank you. Thank you, Agnes.
Thank you, Sita.
Yes, thank you very much, Agnes, and very warm greetings to Gifty and to our dear friends at the UNFPA. Just real quickly, it's clear that a game changer, hi Gifty, in overall in our work on implants had to do with the volume discounts that were negotiated more than a decade ago. And that was really a change, a massive change globally in terms of implant programming. So I'm curious now, as we continue to see the steady increase, can we go back to the negotiating table with the various providers and look for even deeper discounts, and also perhaps engage the private sector as we do so? be happy to hear what the plans are for that discussion. Thanks.
Thank you, Bruce. I'm sure, I think Gifty has stepped off to another meeting, but certainly our supply chain management unit continuously works on negotiating with suppliers for reduction. So certainly that will be on the table, and we look forward to seeing how those discussions will evolve given the demand that we are seeing for implants.
Yes.
Oh, Gifty, you're back. Sorry.
Yes, no, thank you so much. Thank you. I'm back and I was listening attentively. Thank you, Agnes. Correct. We as we improve our strategic demand forecasting, we are going to have better data. And I want to take the opportunity to talk about the Global Family Planning Fund, which UNFPA is investing in, because this is hopefully going to give us visibility into where the commodities are and how much you have, and it would inform manufacturers' planning and purchasing of commodities. So yes, we should be in a better situation to negotiate better prices. Thank you so much. And Bruce, really nice to have you.
Lovely to see you all.
Well, thank you all. We have come to the end of our webinar. We hope you really enjoyed this discussion and all the resources that have been shared. We will be sending out the recording and the slide deck to everyone who had registered. Once again, a big thank you to the presenters today for the great work and their time. And thank you all for taking the time to attend this webinar. Please look out for more announcements, because this is the first of a series. So we'll be doing more similar webinars in the future. Thank you all very much. I wish you a good day wherever you are. Thank you.